As you had stated earlier, today we are going to go through the WHO new NC model of care. And you've also explained why the need for this model of care. Initially, before we started implementing this model of care in Mombasa, we used to use the FANC approach to antenatal care services, where commonly we used to call the 4 FANC visits. And then as a result of data analysis and the challenges that we experienced in our county, resulting to seeing our number of morbidity from pregnancy and mortality increasing, and even the perinatal mortality being increased, we analyzed ourselves and we realized that the 4 FANC visits were not doing us justice. And that is why we decided to adopt the WHO NUSC model of care, which has been seen to work in other countries and giving them better outcomes both for the mothers and the neonates. So in this model of care of WHO NUSC model of care, the care starts from preconception. So maybe from the listeners, if there is there anyone who can share us any information on the preconception care which is usually offered? You can put the comments on the chat box, as Austin has said. So in short, the preconception care, it is the provision of biomedical. This is the medical care that we offer. For example, for the clients who are having diabetes, we need to control their blood sugars before they conceive. Clients who are hypertensive, we need to have their blood pressure controlled before they conceive so that we do not have complications arising from high blood pressure when they are pregnant. And so many other conditions like HIV, we need to have them virally suppressed before they conceive. And it's also behavioral care and social health interventions to women and couples before they conceive. That is according to WHO in 2021. The aim of preconception care is that we improve maternal and child health. So as you can see, the aim of this care is just to improve the outcomes for the mother and the baby. And the target group for the care is women, of course, of reproductive age, 15 to 49 years, but with specific attention to teenage girls. Why teenage girls? Because one, the number of teenage pregnancies is on the rise. And again, we know there are more complications with teenagers because when they conceive during the early stages, most of them cannot cope up and their bodies are not fully developed for that. And refugees and women living in disaster-prone regions because of the hard conditions that they are living in, and the gender-based violence survivors. The main objective of preconception care is that we improve knowledge. We know knowledge is power. If our women are going to be empowered with knowledge, they're going to have enough knowledge to be able to enable them carry the pregnancy in a healthy status and have better attitudes or good attitudes and behaviors for both men and women during pregnancy that will promote better outcomes for the pregnancy. And also to provide evidence-based screening for pregnancy risks. There are a lot of risks that can be health risks that can pose danger to women who are pregnant, so that which can lead to poor outcomes during labor and delivery to these women who are intending to conceive. So the preconception care aims, his objective is to screen these women for conditions that need to be taken care of, for these women to have better outcomes when they conceive. For example, their genetic conditions, screening for HIV, screening for sexually transmitted infections, screening for anemia, so that we can manage these conditions and these mothers can carry their pregnancy while they're in good state. And also to provide interventions to address the risk, as I've said, and to achieve universal coverage of essential obstetric care. The main focus is in preconception care management of long-term conditions, such as I've said, the diabetes, hypertension, and the others that we know. and assist in seizing risky behaviors which can lead to poor outcomes, such as those women of reproductive age who are engaging in unprotected sex or at constant risk of acquiring HIV due to the risky behaviors that they are having. We need to focus them so that we prevent transmission of HIV from mother to baby. Right now we have PrEP, and also promote healthy behaviors for these women so that they can carry their pregnancy in healthy state. The package of care for preconception care is wide. I'll just mention, we won't go into details because of time. The areas to be addressed are nutrition. The women need to be assessed and managed on their nutritional status. Genetic conditions, we need to do screening for genetic conditions. Environmental health, infertility, sexual and reproductive health and gender rights, teenage and unintended pregnancy. So as we prevent the unintended pregnancy and allow these women to carry the pregnancy only when they are intending. Screening of STI and management of STI to prevent transmission. The same with HIV prevention and control. Mental health, we know the issues of mental health are on the rise. We need to really take care of them mentally so as they do not end up being depressed or end up committing suicide as a result of conception. And for psychoactive substance abuse, tobacco use, and vaccine preventable diseases that these women need to have the vaccines in order to prevent them from acquiring the disease before they conceive, and FGM, so that we can know. This will assist us to know how to assist these women during labor and delivery. The benefits. When we have a good preconception care, it will assist us to reduce maternal and child mortality. In fact, it will assist us to reduce child and maternal and child morbidity and mortality. It will also help us to prevent unintended pregnancy. When we do the assessment and we find these women, some of the women are not ready to conceive during the preconception care, we have an opportunity to counsel them on the preferred family planning methods of choice so that they can use and only conceive when they are ready to conceive. It is also an opportunity to prevent complications during pregnancy and delivery, like I said earlier, in management of those conditions that need to be managed pre-conception or even during pregnancy, and also prevent stillbirth, preterm, low birth weight, birth defects and neonatal infections, and underweight, stunting, vertical transmission of HIV, because if we'll be giving PrEP or if we'll be counseling this client on safe sex, I believe we shall be preventing them from acquiring HIV or other sexually transmitted infections. And as a result, they will also not transmit the same infections to their unborn child. And also lower risk of some childhood cancers and type 2 diabetes, cardiovascular diseases, and others later in life. Now, up to this stage, I think we can now start with antenatal care. Antenatal care is defined as care that is provided by skilled healthcare professionals to pregnant women and adolescent girls in order to ensure the best health conditions or best outcomes for both mother and the baby during pregnancy. So what am I trying to say? This is care that is being given during pregnancy. So as for us to have better outcomes for this mother and the unborn child. The components include risk identification, prevention and management of pregnancy-related or concurrent diseases, and health education. We will see them. We will elaborate on this risk identification and the prevention and management of pregnancy-related conditions in the later slides. Justification. As I had said earlier, we were first using the FANC approach to antenatal care. So why the need for us to have the new WHO model of care? It is because that it was through evidence for those countries that have practiced this model of care. They have seen that the increased perinatal deaths, there were increased perinatal deaths in the 4 focused antenatal model of care. What am I trying to say? When women were coming for only 4 visits, we experienced more perinatal deaths than this new model of care, which is different. In this model of care, the women are coming for more visits than the previous 4 visits. Initially, when the women used to come for the 4 visits, if we can remember, there was a time when they completed the 4 visits, the return date used to be written open. And they were advised only to come back when they were having issues. What happened during that time as they were waiting to be having issues? Most of the times you'll find that they used to experience complications, which were serious in the real sense, but the mothers, according to their understanding, some of them did not see them serious. So they would only come back when the baby had already died, maybe in the uterus. And as a result, it is evidence those who have analyzed data at some point in Mombasa County, you realize we had a lot of mothers with macerated, with MSBs. This was resulted from the 4 NC visits because they used to stay home for a long time after they have completed the 4 visits. For those clients who used to come to start NC at the right time, that is during the first trimester. And it has also been seen to improve, the new model has also been seen to improve safety during pregnancy due to increased assessment to detect complication. You'll see in the later slides that in this new model of care, the women are coming up to 8 visits and there is no open appointments. They are not left to stay at home. They come until when they are ready to deliver. So these frequent visits give us an opportunity to assess them frequently and be able to identify any complication or any problem that the mothers might be having, and action is taken on time. And then there is also improved health system communication and support during pregnancy for the women and family, leading to positive pregnancy experience in total. So as you can see, there are very good reasons. Our main objective is, as we had said earlier, is to have better outcomes for both the mother and the baby. And this new model has been seen to have those better outcomes. This table is giving us a picture of those 8 contacts. Now we call them 8 contacts. Initially in the FANC approach, we used to call them 4 visits. Now we are calling them 8 contacts. The first contact is usually during the first trimester, and it is supposed to be from the time immediately the woman realizes that she's pregnant and up to 12 weeks. And then the second contact is usually in the second trimester, between 12 to 20 weeks. And then the third contact also happens in the second trimester, that is up to 26 weeks. And then in the third trimester now, as you can see, we have several contacts. We have the 4th contact which is supposed to be at 30 weeks. And then the 5th contact at 34 weeks. And then the 6th contact at 36 weeks, 738, and the 8th contact at 40 weeks. As you can see, there is no time that this woman is left to stay at home with an open appointment. So from the contact, as you can see, between the first and the second contact, there is a difference of 8 weeks. That is, if this mother came to start antenatal clinic early enough, there will be a difference of about 8 weeks. Then after that, the third contact, there is a difference of 6 weeks. And after that, the visits, the 4th contact and the 5th contact are 4 weeks apart. Then after 34 weeks, this woman comes after every 2 weeks. And we are reminded that the return for delivery